Okay. Welcome back, everyone. And thank you for being part of the diehards that have stuck around until the very end. It's much appreciated. Okay, we're going to go into the final session of day one. And we're looking at health tech and the future of health delivery. The session is going to take place in two parts. We're going to have some opening remarks by Frank Hester, who is the CEO and founder of TPP. And then I am going to be joined by a panel of specialists who've just given me a crash course in the future of health tech. And we'll see if I picked any of that up. And we'll have a bit of a discussion around what the future of healthcare might look like, should look like. But without further ado, I'd like to invite Frank Hester to the stage for some opening remarks.
Try and keep this lively. Well, I'll back off from the mic. So my name is Frank. I'm the CEO and founder of TPP. We do medical software for doctors. And I want to talk briefly to you about health tech in the Commonwealth and what I feel our joint priorities should be. And really what I want to talk about is I started computer programming when I was 14, and I'm 56 now. And in computing terms, that's like thousands of years. You know, so much has changed. And what we could do when I started is nothing compared, we were just chatting, it's astonishing what technology can do now, and it blows me away all the time. So I learned to write computer programs when I was 14, and I was at school. We didn't actually have a computer. The teacher pretended to be a computer, and we had to write things down, and he said that what the computer would have done if we had a computer. I thought it was fascinating. It was more interesting than my current hobby, which was jigsaws. So if you're bored by this, I can talk about jigsaws, and that will send you to sleep. But we got going with it. My mum and dad were immigrants from Ireland, and they weren't very technical. Mum was afraid that because we had a gas supply in the house, my mum was terrified the house was going to explode every night. I won't even tell you about the electricity and what used to happen with that. In fact, all my mum's fiddling about with the gas and electricity made it a total danger zone to be anywhere near the house. But they ran a building business. And every week, Mum would spend maybe a day and a half doing the payroll, the VAT. So we're just adding up the total pay that week, the total pay today, working out the tax on that. All fairly straightforward. And they'd been going maybe 17, 20 years, and they had a workforce of about 15 people. And I just thought it would be an interesting project to computerize some of this. Mum was more supportive than Dad. Dad was just like, there's absolutely no way that's going to work. It's a stupid idea. So that was Dad. Mum was, when I say more supportive, not that supportive either. But anyway, so I wrote some computer programs. And basically that day and a half changed into about 10, 15 minutes for Mum. Their lives were transformed. Within 2 years, they were employing 120, 150 people. They became millionaires overnight. And I witnessed this at a very young age. And I could see the power of IT. And they actually started going out for romantic meals as well. That was a bit creepy for the children. It's like, but I could see the power of IT and what it could do. I then went on to work in a large retail bank, and it was the same story. It was that power. You could just transform things. You could do things, well, 1 million times faster than a human could do it. And at the bank, you could see we made less mistakes, we could employ fewer people, we could give the customers a better experience. And then round about the age of 29, I decided to work in healthcare. I'd, like all of us, I'd had some experiences of healthcare, and I think what inspired me was my dad had an ongoing disease, and we knew he was going to die. But when he arrived in hospital, they gave him the wrong treatment. And it was because they didn't have the medical records from the GP available. And my mum got the wrong treatment when she went in, you know, they messed up her on-admission drugs. So she couldn't swallow, and we were putting onto end of life. And our local hospital in Leeds managed to take out my sister's appendix 3 times, right? I'll tell you exactly how that happened, Dr. later. But unbelievably. Now, all these things are not the faults of doctors. They were all presented with the wrong information when they happened. I think the doctors we have in Leeds are absolutely fantastic, and I'm sure they're just as good all over the world. But if you put the wrong information in front of somebody, they're going to make the wrong decision. So I'm very passionate about healthcare systems for doctors, and that's what I've been doing since I was 29. And what I've seen over that, we started joining up the healthcare in the UK. We look after about 60 million patients now. And you can see the medical record all the way through. Very early on, very quickly, you could see that it was going to save lives. And doctors told us that it did, that they made different decisions, and they could see what other doctors thought. And the other thing that's different was back in the day, you could have a computer that would run a clinic, or more recently, a hospital. But computers are so advanced now, I really think the idea of doing a hospital is now about 15, maybe 20 years old. We've been able to run a country on one computer, really for 25 years. You know, we've had that much spare capacity. So I really want to talk about national EMRs. Much more sophisticated, much more in-depth systems. And you're not trying to communicate through different, disparate systems. And what comes with that, if we look at what's happening in the UK at the moment, you have the data. We have it. And about 2 years before COVID, we started building artificial intelligence. And I was just mentioning there, and it was an unbelievable, fantastic moment. We were able to predict ovarian cancer, bowel cancer, prostate cancer, and lung cancer about 50, 60% of the time before or the need for a cancer referral, I beg your pardon, before a GP would spot it. We're able to predict about 60% of what a GP would ask you. We can replicate the consultation up to 60%. The possibilities for this are astonishing, especially in parts of the world where, well, in fact, it's every part of the world where we don't have enough doctors. There isn't a country in the world that says, oh, it's fine, you know, we've got loads of doctors here, we've got loads of nurses. Nobody's got too many doctors. And the AI can sit with the doctor. Specifically in the Commonwealth, I know a lot of projects where the WHO come in, they sponsor something. It's to work on diabetes or a particular thing, newborn babies. The project runs for 3 years, 4 years, and then they go again. And you're left with nothing. And what I really want the Commonwealth to think about is having a national EMR. When you've got a national electronic medical record, you can run any project you want. You can run any surveillance that you want. Disease outbreaks. You don't need to build an outbreak reporting system It's inbuilt into the system. The research is already there. You just pass the research to your universities. The ability to research is already in it. In fact, I'm looking at Ben Goldacre here. When COVID broke out, we managed to set up a research database for COVID in a very, very quick time. And we didn't do much in my organization, but we just made sure the university got the stuff. And they did a marvelous job researching. It was the biggest COVID research database on the planet. And these are the sort of things that come for free. I'm just wondering which bit to miss out. And the other thing that's changed, although you might not have noticed, is in all areas of technology for the past 20 years, technology's got cheaper and cheaper and cheaper, and it's more efficient, you can do more. Apart from one remarkable industry, the software vendors for IT in healthcare, it hasn't changed at all. We've managed to maintain these fabulous high prices, and people are still paying them. And I want you to have a takeaway moment here. What I've seen around the world is people spending hundreds of millions of pounds on a hospital system, which is really not worth it. And they're not that good. It's a case of the emperor's new clothes. And nobody really realizes it. And I'm expecting a dramatic price drop over the next few years. We can now do a country at scale, doing everything, all the hospitals, all the clinics, for about half of the price that some of the London hospitals are paying for their medical systems. Now, this moment was always going to come. I'm just telling you it's come a bit sooner than you thought. And it's going to be a rather interesting change. A little bit like, everybody knew Kodak. Kodak was there. Nobody ever thought Kodak would go out of business. But when it happened very, very quickly. So, we're talking to Cameroon. Jamaica are just taking a national EMR across the whole of it. We've got about 5 other countries lined up. We're in late stage talks with. And I think it's something that you might want to consider. You don't have to get one from us. We just happen to be the only people doing it. But I wanted to think about it. It will give you more opportunities. You will end up saving more lives just by the fact that you're connected. They're cheaper to run and they're more efficient. And perhaps I'll finish with this. As I go around the world, I see different levels of IT literacy in healthcare. Singapore's, quite high, or Malaysia's a different level, But what I would say to you is, no matter what you've got at the moment, you've got the opportunity to have it a whole load better than the USA. Yeah. And I think what's been delivered over the past 20 years is absolute rubbish. And I think it takes doctors and nurses more time. They don't even know it yet. They think it's okay, but it takes time, and their time is precious. And we need better systems for them. So I've tried to be a little bit controversial. I hope that was controversial enough for you. And we'll give the panel some things to bounce off there. So that's it. Thank you very much.
Thank you very much, Frank. I thought that was great. And I think the level of controversy was entirely adequate. And the the image of a teacher impersonating a computer is one that I'll keep with me for some time. We're going to build on that. Lots to digest there. At this point, I would like to invite up on stage to join me Dr. John Perry, as Clinical Director with TPP, Dr. Ben Goldacre, who is Director of the Barnett Institute for Applied Data Science at the University of Oxford, Dr. Desi Raja, who is the Director and Chair of Malaysia Digital Economy, and Professor Asif Chowdhury, who's a surgeon at the Royal Marsden. All right, gents, thank you so much for joining us. Pleasure to have you. I think Frank has set us up quite nicely to have this conversation, looking at the future of healthcare. One of the things that really stood out for me, and this is very much from a layman's perspective, is, well, to some extent, he was suggesting, do we really need hospitals? And when you hear that, you kind of think, well, of course we do. How else are you going to do healthcare? But of course, a few years ago, you would have said the same thing about a bank branch, right? Do we really need a bank branch? Yeah, of course you do. How else are you going to do your banking? When was the last time you were in a bank branch, right? I can't remember the last time I visited my bank. Point being, technology can and does transform systems. And another thing that really stood out for me in Frank's comments is, the power of information and knowledge, knowing and what that does and what that potentially can do. So those are some of the things that really stood out for me. What I'd love to do with this panel is to expand on some of that and get some of your perspectives on what else is driving the future of healthcare, and specifically technology. Now, to get that ball rolling, here's what I'll do. I will just throw a fairly simple, open question at you. I'll give you a couple of minutes each to respond, and that's also an opportunity to provide any more context that you want to add in terms of the work you're doing, where you're coming from, where you see some of the exciting, important trends and changes that are redefining, reshaping the world of healthcare. And the question is quite simple, is in a few simple sentences, what is the future of health tech and health delivery to you? John, you are sitting next to me, so you're going to be picked on first, and then we'll go down the roster. 2-3 minutes, and if you want to add any more context or perspectives, please feel free to do so.
Okay, thank you very much. Yeah, certainly I do have to add the context that I work with Frank. I work for TPP as clinical director, and I've had enormous privilege and pleasure of traveling around the world and seeing how healthcare is delivered. And I think there is a great deal of disruption of healthcare, hugely accelerated by the COVID pandemic, of course, because of the need to deliver healthcare in a safe way. And so I think, yes, your premise, do we still need hospitals? Do we need healthcare provider institutions? What is it that should be central to how healthcare is delivered? And I think my experience is that what we must put first and foremost is the patient record. If the data for that patient is in one place, then that gives the patient or the citizen the ability to take that with them wherever they go for care. And it's breaking down that boundary that I think is the bit that I'm interested in, because if the citizen has the knowledge of themselves, the knowledge of their healthcare record available to them, they can carry that with them. And that means that they are then less likely to have unnecessary duplicate tests made. They're going to hopefully receive safer care because the drug allergy that they have had recorded in the past is available, they know it, and they can pass it on to the health carer. So I think what I see is more around where does a fully interoperable shared medical record, where does that put us now? And I think it needs obviously to have benefits for everybody. It needs to benefit the patient. I think that goes without saying. It needs to benefit the payer. Well, I think that goes without saying as well, because whoever is paying, whether it's the government or a private insurance company, they're going to see the benefit of reduction in cost, more efficient care. And also, I think the provider. I think many providers are concerned, should we be sharing medical records? Does that expose what we are doing to more scrutiny? Well, it does. It makes care more transparent. But I think that actually it will make provider care, again, more efficient, because they will have the benefit of what has gone before, what treatment has been tried before, what has failed. Later, I'm sure we might get on to a little bit about genomics and how pharmacogenomics, for example, is an incredibly important area where information that you know about the patient will change the way you treat them. It will change your prescribing. It'll make care right first time. And I think all of those things together mean that we are seeing disruption to healthcare delivery. We'll still need hospitals. I'm sure we'll come to that conclusion eventually. But so that's what I'm going to say so far.
But probably not as many.
Yeah.
Right, great, John. Great way to kick things off. Ben, over to you.
So I think the interesting challenge in this space is to make better use of data and evidence not an exceptional thing that we do occasionally, but to embed it in routine clinical activity to make it the boring humdrum every day. So medicine tells a story about itself to itself and to other people. We say that it's a profession that's driven by data and evidence. The problem is that that tends to be in little isolated pockets. So you'll have one beautifully conducted randomized trial, which is the gold standard of which treatment works best, comparing two things head to head, but it'll be needlessly expensive. It'll be constrained by a lot of unnecessary red tape, but also it'll be logistically overcomplicated. And so we don't do all of the trials that we should be doing on head-to-head comparisons that allow us to iteratively improve care. You'll get an isolated audit monitoring the activity or the infection rate in one surgery, or looking at the variation in use of antibiotics or use of high-cost drugs, done manually for one question once a year in a small set of practices or hospitals. What we should be leaping for, and what is actually, I think, harder than doing some sort of theoretically highfalutin artificial intelligence, what we should be leaping for is driving down the cost of every trial, driving down the cost of every audit, making it an everyday part of healthcare in the same way that we have an expectation that there'll be chairs in the waiting room and a person to greet you when you check in for your appointment. I think we have to make it boring and humdrum. And I think the interesting thing about that is, I'm a prof at Oxford. It's a research university. It's ranked the best research university in the world. Dare I say it, not to go on about it. But I can honestly say, as somebody who does logistic regressions and thinks about machine learning and complex statistical analyses for a living, that is not as difficult as embedding gold standard best use of data and evidence in everyday routine care. That kind of practical applied use of data and evidence is harder, and it's probably also where all the biggest opportunities are to save money, improve care, and reduce errors.
Why is it so hard?
It's hard in part because, so the way that you do it involves better organization of care, so management and leadership. It requires that you have people who understand medicine, but also people who understand software. Software is really hard. Medicine's really hard. You need people who understand a bit of both. And those people are unicorns. We don't have enough people like that. We haven't trained enough people like that. I think it's also hard because it's easy to fake. So we don't have a rational market that recognizes and rewards when people have done it well. You can throw a lot of money at pretending to build a data-driven health service. You can get the graphs with a nice color palette that convince your boss or your health minister or your chief exec that you've done a great job. But if they don't have the technical skills to tell the difference between real delivery and pseudo-delivery, then you won't have a rational market that rewards people who've done a good job and gradually edges away from people who are just faking it.
Great. Thank you, Ben. Desi.
Yeah, so to me, fundamentally, when you speak about health tech or digital health, I still feel that we are lacking behind fintech, insurtech, agri-tech, retail, etc. And in Asia-Pac, fundamentally why we are facing this issue is, I think we are not addressing four main components, because if you see tech companies today, like I think what John just said, pharmacogenomics, genomics, or whether it's AI or whether it's blockchain, Prof. Ben mentioned earlier, I think there are a lot of applications that are built in silos, and most companies are actually working towards a B2G kind of model. So they want to promote those solutions to governments. But as I said earlier, whether it's a B2G model or whether it's a B2B model or whether it's a B2C model, fundamentally the 4 points, basically the strategy, the technical and technological component, basically the stakeholders that are involved to draft those how do we classify data? I mean, how do we tier those data? Which health data should be categorized under classified or non-classified? For example, in public health, mainly, like for example in Malaysia, most of the disease outbreak, public health data is anonymized. Basically, we don't need the name of the patient. So, this technical and technological component. And the third component is the legal and regulatory framework. I think this is another challenging component that has yet to be addressed globally by governments of the day. And finally, how do you operationalize the strategy, the technical, the technological, as well as the legal and regulatory framework? So I think in order for, we can keep talking about technology, we can keep talking about AI, but as long as we don't solve these four major components, I think it's kind of difficult to move. It's difficult for health tech to move or to grow exponentially. And fundamentally, I think it needs political will as well as reconfiguration of the country's objective if we would like to see health tech where fintech is today.
Just a quick follow-up on the issue of legal and regulatory obstacles. Is the issue simply opposition? Are governments simply blocking the adoption of technology, or is it that they're ignorant of it, or maybe just not interested in it? Because when you say that, I can't help but think of the mobile money story, which kind of sinks or swims based on the regulatory approach, and where governments have taken a hostile approach, it just hasn't really taken taken root. Is it a similar dynamic?
So. Speaking about Asia Pacific, I think different countries or different regions have different digital maturity here. So, countries like are very much brownfield, they are kind of accepting changes. They are not really accepting changes. But countries that are greenfield, they are a bit more adaptive to new changes, new technology, new advice. And secondly, in order to drive, because see, the fundamental data sharing is always an important component, whether I was previously in the Ministry of Health for 12 years, then in the corporate sector. So what I realized, everyone tends to know that data sharing is needed, is possible, like what John, we mentioned earlier. But to actually drive that is very difficult because even Prof. Ben mentioned, you need the right people, the right knowledge, the right person to sit in that committee. As long as they don't sit in that right committee, you can't push or you can't move anything ahead. And I believe personally, familiarity drives maturity later. So you got to get people to understand and the right people to sit to make this decision.
Great, thank you. Yeah. Asif.
Yeah, my take is slightly different. I'm a jobbing robotic esophageal cancer surgeon. I work and interface directly with patients at the Royal Marsden, world's oldest cancer hospital. What I want to see is I want to see a future in which cancers are detected early, at a point at which we can actually do something about them, at a point at which by the time they get to the sort of complex operations I do, they're mutilated less, the intervention is smaller, they get back into their normal daily lives and economic activity sooner. And I want the whole of that journey to be improved by the integration of technology. And what that perhaps might mean is predictive technologies embedded at primary care level to see what symptoms can predict earlier cancers, and then there could be a degree of automation of referral to a clinician who can actually do something about it. All cancers don't present with symptoms. Many present with other changes in patients' physiology or their biochemistry. And if there are ways of interfacing with the patient through sensors, or, as we heard about in the last session, and if that can be integrated with an electronic patient record system that can then integrate with secondary care, that whole process of obstacles getting to the point at which any meaningful intervention can take place would obviously be improved. One of the things that we learned during the whole of the COVID period, going back to your question about whether or not hospitals should exist or not, is that actually we don't need the footfall in hospitals that we have had all the time. A lot of things can be done remotely. We can have virtual consultations, we can have advisory consultations, we can work in a multidisciplinary way with all of our associate specialists and nurses and dietitians and everybody else together with the patient whilst they remain in their home or ambulatory environment without bringing them into the hospital and disrupting their daily life. But then when it comes to the intervention of surgery or interventional diagnostics as well, like endoscopy, we have to get into the patient, and then they absolutely have to be with us at that time. But the hope I have is that when we do carry out surgery, it can be as minimally invasive as possible. And so as a robotic surgeon, what I'm witnessing is really now the sort of third or the fourth generation of technical evolution and the convergence of optics, mechatronics, digital technology in general for me to be able to look into the individual's body, see a three-dimensional view, and have my movements outside the patient miniaturized and myself magnified, looking closer and closer to the tissues that I want to preserve inside the body and the pathology that I want to remove whilst disrupting things as little as possible. Okay, and so much work is now being done to try to bring together things like CT images, radiological images, and to sort of enmesh them onto organs within a dynamic state in the body so that the actual act of surgery becomes less risky. So it's not just about a proficient expert with their authority predicting where they should go, causing a disruption, and then dealing with it later, but actually preventing that problem from starting. And I think that in the future there will be a lot more opportunity to gain data from the actual act of surgery within the body, textural, visual information that can then be codified, and then people can develop the appropriate algorithms to extract some sort of data from that can help novice surgeons or trainee surgeons or surgeons who aren't the super specialists who at the moment can only ever treat a small proportion of all patients.
I think it's a great vision. What are the big obstacles that you see?
Obstacles. So I think with any technology, it has to be safe in its integration. And convincing the right people, as Deshi said as well, and having the right people around the table, the influencers who are going to actually allow you to take the next step or put the money in for integration within your physical hospital is always difficult. Making that case when you're an innovator or an early adopter, a pioneer or an early adopter is often difficult without evidence. But often continuing with the same evidence base that we actually have can be restrictive. So perhaps we need to take sort of small steps and gather more real-time evidence. So, the difficulty we've had in medicine for a long time is having big-scale head-to-head trials is very expensive, cumbersome, organizationally it's very difficult to answer a question that by the time you actually get the answer, the technology has already moved on, solutions are already better, and you could have just continued with the same, almost sort of dinosaur attitude of persisting, but you don't necessarily get change that ultimately improves health for patients by doing that.
Great. Thank you so much. Now, quite a few things have come to the fore here. One of the threads that seems to be running through a lot of the comments that you've made is data. Now, we live in the age of data, right? The age of big data. The likes of Google and co are hoovering up more data than we can get our heads around. What makes medical data and data in the medical profession so tricky and complicated? Isn't it, and I'm sort of asking a deliberately simplistic question here. Don't you just call up Google and say, can you sort this out for us? Doesn't the capacity and technology exist? What makes it so hard? And it's a general question to the whole panel. Would anyone like to kick off? Yeah, you volunteered.
Well, while you draw breath, the quintessential thing for me about the difference that we always have to remember, which is blindingly obvious, is that if the bank makes a mistake with your data, they can just put some more money into your account, fine. If we make a mistake with your data and the next door neighbor finds out that you've got something wrong with you, you can never recover from that position. And for me, that sets the scene for all the data security stuff we talk about, or all the cyber security, all the storage, all the problems potentially of re-identifying even anonymized data. And Dr. Goldacre, Professor Goldacre knows a lot more about this than I do. But once you start to accumulate a lot of data, it's very easy potentially to find out who that individual is because of the amount of stuff we put on social media. You know, I had a good experience in my local hospital last week with my operation, and I know you're 43 and I know where you live, and actually by triangulating that, you could start to unpick the data and find out what's going on with that individual. So for me, it's the quintessential nature of medical data that once it's out, you can't recover from it. Sorry, Ben.
No, I think that's all very true. The big challenge with health data is, on the one hand, an entire nation's detailed electronic health records are an absolute goldmine. You can use it to understand which treatments work best, which have side effects, and in which patients. You can help it to spot failing surgeons or brilliant surgeons and hospitals that others should learn from. You can use it to innovate in your life sciences sector. But the challenge is the same data you use to do all of that good stuff also contains the deepest medical secrets of every single citizen in your country. And so you have to manage it very carefully. Now, in collaboration with TPP, we built Open Safely, which is a way of managing privacy whilst also giving access to data for research, and it's all free and open source software that sits on top of TPP's data center. That's one way of approaching it, but I think what was unusual about that collaboration is that we recognized the problem in the first place and set out to engineer around it rather than trying to persuade government. Because I think one of the problems in this space is that people often think people who are raising worries about privacy are just irritants who are in the way, whereas actually they've got very reasonable concerns and you need to build good risk mitigations to manage that risk. I think, lastly, one of the most dangerous myths that's taken root with health data and with data in general over the last 10 years is that people have talked about data as being the oil of the 21st century. I think it's actually more appropriate to say that it's the nuclear material of the 21st century. So you can buy uranium on Amazon, you pay about $35, and you get a flask of water that contains 2 atoms of uranium, and element collectors buy it. That on its own is not powerful and it's not dangerous. Uranium becomes something that is qualitatively different when you refine it, when you compress it together. You get something that is incredibly powerful. It can generate energy, it can blow up buildings, but it's also incredibly dangerous. Once it leaks, it can't be unleaked. And I think one of the problems that we've seen in the role of government to provide a kind of fertile pond for people to innovate in is that they haven't, in most countries, worked out the right place to put the guide rails. They haven't had enough people with technical skills to be able to understand which things to block and which things to nourish. And so I've seen in many countries, including in the UK, things which were manifestly safe and wise get bound up in lots of anxiety and not happen for many years and sometimes get blocked outright. At the same time, I've seen many things which I personally thought were very unwise get nodded through. And I think if government can just develop the technical expertise around managing the benefits and the hazards of data in the same way that we have with nuclear material, then we'll get a lot further.
Yeah, I was going to say, I like the uranium analogy, but of course uranium is handled and managed all around the world all the time, right? I mean,
Well, it's handled and managed, and it generates a vast percentage of the electricity in France, and we buy it from France because they've worked out how to manage and mitigate those risks, rather than just take risks or be paralysed by anxiety,
Yeah.
or be tossed on the winds of whichever charismatic lobbyist you last saw. It is possible to manage these risks, but you need clueful people to do it.
I think just add a very small point on the uranium thing. So in the surgical world, we have a lot of visual data that comes from operations which we use cameras and so on. But it's being mined by data mining companies, the producers of the machines that actually are the interface between the surgeon and the patient. Then it stays in silos in hospitals, and no one quite knows what to do with it after that, or how we can actually extract any value out of it. We have lots of ideas and thoughts about it, and then lots of little pilots, but it's very difficult to move beyond that point until we get to this kind of collaborative, safe space.
Desi, did you want to comment on this, or?
Yeah. Basically, I think it's fundamentally back to data sharing, right? So I think most governments today, I think they tend to draft this regulatory and legal framework and just push it down to everyone to probably just follow these guidelines. But it is important to get all these particular stakeholders to be part, because as you know, data is, basically you have data generators, data processors, data users. So you just got to get every stakeholders to be part of this life cycle, or every stages of life cycle to generate this data. So it's sad that we are in 2022 and we are still talking about data sharing, because it's been an ongoing thing. You know, we have conferences, we have white papers, we have blueprints, but to execute that has always been a great challenge.
And it sounds to me like part of the difficulty there is governments can take a large amount of time to move on these kinds of things, especially if there are genuine sensitivities around, you know, the data sets that you're dealing with, and technology moves so rapidly. You touched on that earlier, that it's kind of like, it almost seems like a bit of an impossible combination here to have government regulation that is so dynamic and flexible and on the money and accurate, and, you know, takes into consideration the privacy concerns to keep up with technology. But that, of course, doesn't mean you throw in the towel and give up the fight. Turning to the broader picture of the Commonwealth, and particularly those parts of the world that you would, I guess, class as emerging or developing countries. Because on the one hand, it seems to me fairly self-evident that there are tremendous benefits to, potential benefits to healthcare systems in less developed economies on the back of digitalization, digital communication. But on the other hand, it also sounds to me like some of this stuff is quite high-end and expensive, and therefore tricky to deploy in a part of the world where you might not have the capacity, the infrastructure. I'd like to get your thoughts on what this looks like in a setting, let's say Sub-Saharan Africa, let's say Southeast Asia, you know, let's say South America, or wherever you might want to take. Is the discussion there materially different about the future of healthcare? What are some of the priorities, some of the opportunities you see there? John, is that something that you'd want to comment on?
Yeah, certainly. I think following on from what Frank said earlier, I think the major disruption to affordability of national level electronic patient records is something that is in the moment. That is the thing that we're really talking about. I think the technological platform, you know, we have the opportunity for many countries to leapfrog where we've been in the UK for a number of years, because, you know, mobile phone penetration is high in many countries. We have internet connectivity. We have a way of delivering internet connectivity from satellite clusters or whatever to get to the point where this should not be a barrier. I think what is fascinating, of course, is, especially for the Commonwealth, the very young age of very large numbers of the population. So what we've used that terrible expression, the burden of disease of the older population, the diabetics, the people just living a very long time and developing more cancers. We have the opposite problem, where we need to make sure that antenatal care is optimized, that the care of newborn children, the recording and monitoring of vaccination rates, And of course, as Sir Patrick Vallance was saying earlier, actually making surveillance, he used the word surveillance, of what's going on in the population absolutely routine. We need to spot outbreaks from routine collected data in healthcare systems. It's something that we do in this country by providing data feeds from primary care sources. So I think in general, I think the idea of being able to deliver this in any country is both realistic and also our obligation to make sure that the systems are affordable and suitable for whatever the local and national priority is in whichever country that we're talking to. And I think colleagues, and Frank especially, have visited a number of African states, and we find a real commonality of purpose, a desire to actually benefit from both the having the proper electronic medical record in the local institution, the ability to see the data and benefit from the data, as Professor Goldacre has mentioned, and actually move forward in a way that means that we can deliver tailored healthcare accurately, reliably, safely to all of those citizens. So yeah, I think the moment is now, definitely.
I like the idea of leapfrogging. I think you've got to be careful with that term because, it might be sort of overly optimistic, but it seems intuitive that the application of technology will at least be able to deliver some benefits pretty much regardless of where you are on the development scale.
And I suppose what I'm really alluding to is that one can go straight to cloud, straight to connectivity, rather than actually worrying about endless local server installations in every institution. You can actually build in some of the safety for example, natural disasters by actually moving away from local institution-based. Almost you're getting rid of the hospitals. You can get rid of the IT in the hospitals to make sure that you've always got continuous access to your data.
Would anyone else like to comment on this?
So I think if you look at surgery globally, there are about 310 million operations done a year. We probably need another 150 million to save the 17 million or so lives that are lost every year because of inadequate access to surgery. Now, bricks and mortar hospitals, infrastructure costs money. The investment needed by governments to actually build that in place, to put that in place in the first place, is difficult in many parts of the world, particularly in sub-Saharan Africa, perhaps. If we can get to a point of efficiency through appropriate healthcare systems to make it simpler for doctors and nurses and health workers to actually identify disease, surely we'll get there faster in terms of actually reducing those deaths. Perhaps by having decentralized systems or systems in which proficient, knowledgeable clinicians can actually remotely connect with people more dispersed within society without the need for bricks and mortar hospitals will also make things faster and better for the populace.
Well, just to add, I think fundamentally here we're talking about using data and computers to organize care more efficiently. And one thing that I see really holds back the health service in my country is we're hindered by being early adopters of technology. And that sounds paradoxical, but I think when you have a country like the UK, where so much of the health service was computerized a long time ago, what you end up with is systems and approaches that are set in stone. And I think there are a few things I can picture that would be more exciting than starting afresh and having that opportunity to not have to deal with the kind of legacy systems that we have in the UK. For better or for worse, doctors in particular can often be very good at building little principalities around themselves. Hospitals also, GP practices also. And that can compound the problems of technical interoperability, which I think are often the smallest barrier to interoperability. Often you'll find in England the same technical platform in different hospitals has been configured needlessly in a way that gradually makes it more and more walled off from all of its neighbours. The prospect of starting afresh without having to address quite so many of those dreary small p political problems between little principalities in a health service. Sounds like heaven to me.
Yeah, and it's unfortunate to hear that those are obstacles, but one can see why, right? The logic behind it. But it's a pity because it seems to be holding back some fairly important changes. Desi, did you want to comment?
Yeah. So to me, again, I'll fall back to policy and data sharing, because I think we heard many pandemic preparedness program. I mean, myself, I'm an epidemiologist. So looking at, I did some work during the Rio Olympics for Zika and dengue. Did some work in Philippines previously and also helped the GCC. But fundamentally, why I think, as much as we say that we've got to use AI, we've got to use technology, we've got to use data to build a better surveillance system. But fundamentally, let's look at IHR 2005, which is the International Health Regulation 2005. It's basically a policy or a written paper that tells every country to report to WHO alone, not inter-countries. So that's one fundamental issue with data flow, basically. And second, we have something by WHO called GOAN, G-O-A-R-N, the Global Outbreak Response Network. Even that is a paper about how do we actually report cases from our respective country to WHO. And I think we have another paper, I think, by WHO, which is the PHEIC, which is the Public Health Emergency and of International Concern. So I think fundamentally we have everything there, but it's about having the right mindset and the right people to actually discuss and debate about this, because I think fundamentally contestational of ideas between governments, private sector, academia, it's important, because if not, we're still going to repeat the same thing, building surveillance systems without understanding that the data flow has to be multilateral, multinational, instead of reporting on an incremental basis to WHO. So I think in a nutshell, instead of systematic changes, I think a systemic changes is needed in order for us to drive this. Yeah.
We only have a few minutes left. What I'd like to do in that time is pick your brains on what the next few years might look like. Are we going to see an increase in disruption? Or are we going to see more inertia? And where's the real change coming from? Where is it going to come from? If you had to put money on it, figuratively speaking. John, putting you on the spot.
Well, the future's already here. It's not evenly distributed, I think, is what we always say, but it is true. I think, building on previous comments, I think patient activation is a term that's used a lot in the NHS. I think actually putting the citizen more in the driving seat, enabling them through education and resources through the internet to understand more of what's happening with their own bodies and with their own healthcare. I think that's the next disruptor for me, because I want people to be able to understand what's going on, to drive their own healthcare, to make sure they're getting the best possible healthcare. At the opposite end, and again, completely agreeing with what's already been said, that data will also enable us to make sure that people are getting standardized, optimized, efficient, safe care. We should be looking at both of these things simultaneously. And I think you're right, there will be inertia, but I think we will see nations across the world adopting the national EMR approach and actually saying, no, we can now deliver this because the technology is there, it's affordable, we can make it happen. And I think then that will trigger other countries to learn from that. That's my hope.
So I'll follow you under optimistic.
Yeah, definitely optimistic.
I think it could be extraordinary or it could be a dead squib for the next few years with data in healthcare. I think what will make it extraordinary would be if we can use regulation, contracts and incentives to make sure that we create markets that align the incentives for governments, health services, vendors and patients. So for example, a health service wants large amounts of data aggregated so that it can use it to monitor and improve the care in all of its institutions, but it has to also make sure that it's protecting patients' privacy while it's doing it. Governments might recognize that they need to intervene, to invest, to have large volumes of data created and managed up front in their health service. Governments also, I think, have a legitimate interest in saying, for example, that all of the commercial innovation that can be done in this data should create a return back to this country. That requires that you have cautiously managed markets, that you think carefully around how you get a cut of innovation done in your data, that you think about what your structures are, where you keep that data, and also that you keep patients on board and your population on board. I think if we can get all of those incentives aligned through regulation, incentives, and contracts, then I think the future is great. I think there's probably going to be first mover advantage as well, because I think eventually a small number of countries will crack this, and when they do, they'll lead the world and they'll probably take the prize.
If you had to name a country that you think might be getting it right or is going to get it right, could you reel off a few names?
I won't name any countries, although it might be obvious who I'm implying. I think it's easy to do it in a small country. I think it's also less exciting to do it in a small country. And it's in particular less exciting to do it in a small country that's ethnically homogenous as well. Because the real opportunity is if we can get enough ethnically diverse populations, we don't need to have the whole world, but if we can get enough ethnically diverse populations, then from those nations' data, we can do research which will drive research and innovation in all countries of the world. So to do it well in one small, wealthy country here and there doesn't really impress me.
I'm thinking north of here, but...
Oh, I'm thinking south of here, but
Yeah.
in any case...
I thought you were thinking east of here. Oh, well, okay.
But that's kind of encouraging, right? That it doesn't have to be everyone, but if you get in the right place, you can kind of change the whole thing.
Yeah, I mean, I think the first few to go will set down templates. I think the other interesting thing is that doing it is sufficiently hard that in doing it, you also develop a workforce that have skills that will generalize and be mobile around the world. And they're the hardest kind of skills to build because they're around having deep technical knowledge of medicine and data and computing, but also practical skills around actually implementing something in a system that works. It's kind of easy to computerize your vehicle registration licensing system. The software to do that's quite hard, but vehicle registration is very simple conceptually. Medicine is conceptually very complicated. So is software. So this is a hard one to crack, but whoever cracks it first 5 will take the prize for the globe, I think.
Desi.
Yeah. So, to me, I think in order for us to achieve the ultimate goal in digital health, I think it's important to achieve, every government to achieve the single record, one citizen, one record. Why I'm saying that is because if you do not have data at a personal level from cradle to grave, from womb to tomb, because only when countries have this data, you can meaningfully use, meaningfully make decisions, meaningful data can be made for data-driven decisions or applications or AI or whatsoever. But I think like what John said, like when we moved around from Asia to the Middle East and various continents, I think there's pocket of solutions almost everywhere. But to basically achieve that one citizen, one record is tremendously difficult, even though there are many EMR players around. But to achieve that dream of having every of your citizen online, I would say, is still very challenging. So I think until we achieve that, the other pockets of solutions like, I want to create the best surveillance system, I want to create the best genomic center, I think it's kind of difficult because you don't even got the fundamentals right yet. Basically, you can't even get the patient records online yet. So I think it's going to be very challenging, yeah. Thanks.
Thank you. Final word.
I'm hopeful that the only way is forward with this, because the end drivers of any change in health tech are the end recipients of that health intervention, and they are the patients. And our patients are progressively more tech literate on a daily basis, and that's like there's only one direction that's going to go in. And the same is the case for the providers, the same is the case for the policymakers, where the whole of the planet is normalizing to a more technologically advanced state. And all of the red tape and the regulatory issues will come along with that, I think. And from a technical perspective, in terms of surgery and the rest of it, the degree of convergence is taking place in all of the disciplines that need to come together for that step of eradicating disease are just forever getting better and simpler. So I'm very hopeful.
All right. On that note, I will draw proceedings to a close. Thank you so much for the insight, for the perspectives. Certainly been a learning experience for me. And lots of food for thought. Please join me in thanking our great panel. And that concludes day one. Once again, thank you so much to everyone who has stuck around until the bitter end. Yeah. You're all heroes in your own way. And we'll see you tomorrow morning. Have a good evening and good afternoon. Thank you.